My name is Sean Fitzgerald, and I'm speaking to you today from Jasper. I'd like to begin today's meeting by acknowledging that the College of Physiotherapists of Alberta's offices are located on Treaty 6 territory, as well as the Métis Nation of Alberta's Region 4, which has been and continues to be the home of many Indigenous peoples since time immemorial. The College of Physiotherapists of Alberta recognizes that Indigenous peoples have been helping many live healthy lives on this land long before settlers arrived. With that, we commit ourselves to helping move people forward in their journey towards a good life and doing so in a way that follows the spirit of intent of treaty, that of peace, friendship, and understanding. We also recognize that people from across Alberta and beyond are joining us today and encourage you to take a few moments to learn more about the lands, peoples, and treaties with which you may be in relationship. It is my pleasure to welcome Dr. Aliki Thomas, an Associate Professor in the Faculty of Medicine, Health Sciences at McGill University. Dr. Thomas's research is on education and knowledge translation. She is interested in the development and assessment of advanced clinical competencies, including evidence-based practice, clinical reasoning, decision-making, and the development of professional expertise. She is involved in research on how to bridge the evidence-to-practice gap, where she uses an educational psychology perspective to examine the use of theory in the design and delivery of effective KT interventions. She's also interested in the concept of scholarship of practice and the outcomes of clinical research or partnership on clinical practice. Again, welcome, Dr. Thomas, and I'll hand the presentation over to you.
Thank you very much, Sean, for that lovely introduction, and thank you, the College Physiotherapists of Alberta, for this lovely invitation. I'm really excited to be here with you today. It is a very snowy day in Montreal, but I hear that that's not a foreign concept to you all, so I hope you're all staying warm. So today, my goals are to provide you with a very brief overview of the why and how of evidence-based practice, to describe what are some of the common barriers that we see in our attempts to use evidence-based practice, but also what are some of the facilitators that we can leverage to help us. And I hope to spend most of the time discussing the common strategies that can be used to leverage the supports and overcome the barriers. So just a very, very quick stroll down memory lane. Evidence-based practice or evidence-based medicine originated very early in the 1990s, so almost over 30 years ago. And the ethos and the values of evidence-based practice were really about the idea that uptake of scientific evidence would lead to better patient outcomes and help resource-strained healthcare systems to provide more cost-effective care. So though evidence-based practice began essentially and primarily in medicine, it soon, of course, found itself in other professions, including nursing and physiotherapy and occupational therapy. And for this reason, what we see today are a number of terms that are used interchangeably to refer to a decision-making approach that is based on scientific evidence, and you could see a number of terms here, essentially all converging on the importance of using evidence in our practice. But it didn't stop there, right? So with the emphasis on evidence-based practice, soon what we saw happening is an impetus and a drive for evidence-based practice and evidence-based practice competencies to find themselves into the curricula. So as essential components of the programs that are delivered across Canada, with the aim of helping to prepare a generation of scholarly practitioners or what we hear called evidence-based practitioners. And so this has been happening now for over 20 years. Now, just a very small caveat, a little bit of a pause in the presentation to talk to you about two important conversations that are happening in the literature when it comes to what evidence-based practice actually is. And these two conversations are surrounding what you see on the left, the process of evidence-based practice, and then the attributes. So you might have seen the 5-step process discussed either when you were training in your own programs or through the literature that the evidence-based practice process is a 5-step process where you begin with asking a question that comes from some clinical uncertainty, and then you acquire the evidence and you appraise it, and then through your decision-making and professional reasoning, consider how to apply that evidence, and when the whole process is completed, that you evaluate and reflect on the outcomes and the usefulness of the evidence-based practice approach. But at the same time, there's been a growing attention in the literature, not just on the process, but also on attributes. So what does it actually take in order to be able to enact an evidence-based practice? And I would say enact, but also embrace its ethos and embrace the values of evidence-based practice. So we often hear about it takes knowledge. We need to know about how to read the literature, and we need to have knowledge about a particular evidence-based practice. We need to have positive attitudes. We need to have confidence, right? Confidence in our ability to sift through that evidence, sift through various types of knowledge that we see, and then confidence in our ability to do something about it, to then apply it in practice. But we also have seen attributes related to resources, right? Resources in our workplace, access to libraries, access to information, access to continuing professional development, right? So those kinds of attributes that are more organizational, and support from leaders and managers to help us with the process of evidence-based practice and some of the additional learning that we need to engage in to be up to date. So with that little caveat, what I wanted to present here in the next slide or two is evolution in how we've been thinking about evidence-based practice. So when I went to school and became an occupational therapist, evidence-based medicine or evidence-based practice was represented, and to a large degree still is today, is depicted with these 3 circles, right? So we draw from the scientific evidence, we use our clinical judgment and our experience, and we consider our patients' values and preferences when we make a decision. So those 3 things are constantly interacting. It didn't take very long. It took about 15 or 20 years, I would say, for there to be a huge emphasis on the role of context. So the extent to which the context within which we find ourselves has an influence and actually helps shape the evidence-based practice process. And just to make things a little bit more complex but a little richer, I would argue, came this new model, a newer model, a transdisciplinary model of evidence-based practice, which I show you here. And what you see is that, yes, the 3-circle model is in the middle, but look at the boundaries around it, right? Look at the organizational mandate, our community, right? The organizational resources and constraints. So the inner boundaries pushing or influencing the 3-circle model and suggesting that this is not the EBP process is not happening in a silo, right? And then when you go even broader than that, it suggests that the political context in which we find ourselves, the trends, the changes in our professional context, right, our profession, how it is evolving, and what are the new areas and what are the new competencies, and the historical context in which we find ourselves, and importantly, the economic context in which we find ourselves, have a bearing on the evidence-based practice approach to decision-making. So this now represents a much richer and much more nuanced approach to EBP, and you'll see why this matters when we get into the strategies. Now, that is just to say, you know, yes, there's been a huge drive for evidence-based practice, and I'm sure I don't have to convince any of you of how important it is. So what we've seen in rehabilitation, in your profession, in mine, and in others, is that we create a lot of knowledge from original research. Many of us work very hard at synthesizing that knowledge through via systematic reviews and guidelines. And we spend lots of time publishing in peer-reviewed journals, and we present at conferences, and we present at journal clubs and webinars such as this one. However, we now know there is a robust body of research that these processes are not sufficient to affect knowledge use and change practice. So what this has been called is a research to practice gap, right? This underutilization of available scientific research findings in clinical decision-making and patient care. Every single reference you see at the bottom of this slide comes from rehabilitation. So there's a lot of evidence to suggest that we actually do have research practice gaps in rehabilitation. Now, there are consequences, and this is what is always a bit more worrisome, right? So what? Why should we care about research to practice gaps? Well, there are consequences for clinicians and for clients and the profession and for society. As clinicians, it's important that we stay up to date, that we hone our skills, that we be aware of the latest research evidence. We owe it to our clients and our families and their families to be able to say that the services that we offer are based on the best available evidence. It's also important for our professions to validate what we do, to have a rightful place in the healthcare system, and to argue for the importance and the contribution of our services. And of course, to society. Any health care profession, any self-regulated profession owes it to society to be able to provide excellent care. Now, the solution that has been proposed to bridge that research to practice gap, which I'm sure you pretty much have heard this term before, is knowledge translation. And what is KT? This is the Canadian Institutes of Health Research definition. It's one that's being used all over the globe. It's a dynamic and iterative process. Yes, it includes synthesizing and disseminating evidence, as I said before, but it also includes the exchange and the ethically sound application of knowledge. So exchanging knowledge between researchers and different stakeholders in the hopes of improving the health of our citizens and strengthening our healthcare system. When we talk about knowledge translation, we like to organize KT in terms of these three major steps. And it's really number 3 that I want to spend more time on today. So where is the gap? What does this mean? So where is the gap is when we try to identify the nature and the magnitude of the gap between what is known from the literature and what is actually being done in practice. And these are some examples from rehabilitation, an underutilization of some outcome measures and standardized assessments, the use of some interventions in different areas of practice, stroke being one of them, and then an over-reliance on experience rather than published research, even when the evidence is very compelling and robust. And so there's a tendency to disregard it for some reason because of a very strong belief that that clinical experience sort of trumps the scientific evidence. And we're going to discuss that at the end as well, because I'm not suggesting that clinical experience and acumen are not important. They are vital. So when we go to the second step is, why is there a gap? And I do want to spend a few minutes on this because I think it's important for individual clinicians to know, the clinicians that I work with in our research center who are on the ground, in the trenches, so to speak. I think it's important to recognize that all the onus and responsibility is not on the individual for evidence-based practice. I think that transdisciplinary model spoke to that to some degree. We see barriers, so the sorts of factors that make it difficult coming from 3 different areas. And I just want to spend a couple of minutes walking you through some of these. So yes, there are aspects that are related to us as clinicians. Do we have confidence in our ability to read and appraise the evidence, apply it? How much do we know? How much have we learned on a new practice? Have we embraced an attitude that it is important to stay up to date, that it's going to be important to try to overcome some of those barriers? You know, the notion that sometimes we do things for which we're not compensated or remunerated, which can be disheartening for clinicians when they put in so much effort to try to stay abreast of the literature. The different roles, where clinicians are often 100% clinicians, but in some cases they have other roles as well, which makes for competing priorities. Our philosophies of care and whether those align or not with the scientific evidence. We've had studies showing that the level of education is important and predicts actually just intention to use evidence and actual use of evidence. We're seeing Are newer graduates more inclined to be closer to the evidence? We've suggested that the transition to master's professional level, which has now happened over 20 years ago, has been a driving force for some of that. And then individual professional competencies of clinicians are also factors that can support or hinder one's ability to execute a more evidence-based approach to decision-making. But there's also organizational factors. A culture of efficiency, which we often see. I can't speak for Alberta, but I can speak for Quebec and tell you that there is a growing culture of very heavy caseloads, seeing lots of patients, quick turnover, short waiting lists, relationships between clinicians and relationships between clinicians and managers, leadership and leadership styles that are, embracing and supportive of change, supportive of practitioners spending a little bit more time on reading literature or exchanging with peers on best practices. The resources that are available in the organization, the skill mix that we see across many professionals, how involved different staff are in hospitals and practice settings, and of course the heavy caseloads, which is a reality that we see across Canada. And here it gets at an even higher level, and again brings back those outer boundaries of the transdisciplinary model. There are policies that are being made and mandates from health systems. In Quebec, for example, there are ministerial mandates on the use of new standardized assessments that are sort of trickling down to clinicians and say, well, this is something you will begin to use momentarily. Everybody's going to be expected to use this particular outcome measure. There are economic and financial incentives that we see that come at a policy level that trickle down to what practitioners may or may not do. Dominant paradigms at the time. We're living in a time of a global disruption in the world. We're living in a moment where there's so much positive emphasis on the importance of equity and diversity and inclusion and public awareness of evidence. And so all these aspects that are much more at a systems level have a huge impact on what practitioners do on the ground. And of course, the infrastructures and the advances in technology make it sometimes easier and sometimes a little bit more difficult to engage with the literature and apply it in your practice. So now what do we do about it, right? When I was invited to speak to you today, it was really Aliki, what can we do? What are some of the strategies that we can do? So I'm going to say that I've spent the last 10 to 15 years trying to figure this out. I'm not the only one. There's dozens and dozens of scientists in Canada and across the world that have spent the last 2 decades trying to figure out how to best support evidence-based practice. We're making headway, so no despair here. So I will give you some thoughts on what can be done. I want you to remember that there isn't a one-size-fits-all. If there's something that you take away from today, is that some of the strategies I'm going to propose will work for some and not work for others for the reasons that I gave you in terms of the context specificity of our decision-making process and how our practice settings differ and how individual human behavior differs. So we can't paint every physical therapist and every occupational therapist with the same brush when we think about what will work for whom and under what circumstances. But there is some hope. So KT scientists have spent a lot of time trying to figure this out, and moving evidence into practice and supporting evidence-based practice is under the purview of knowledge translation. That's what KT scientists are doing more and more now. But it is a very systematic process that takes a lot of different things into account, including the nature and magnitude of the gap and all the factors that I described earlier. So we ask, who needs to do what differently? An example that I can give you is screening for post-stroke depression, something we see in some of our rehabilitation sites here. So when we notice that uptake of that best practice, which we see on the Stroke Canadian Best Practice Guidelines, is not happening, then we can figure out how big that problem is. So what is the level of magnitude in one hospital or one rehab site or more than one. And so what is happening exactly, and who needs to do something differently, right? Is it just the practitioners? Is it the managers? So then we draw on, and I won't bore you, so to speak, with all the theoretical frameworks, but we do draw from theories that come from psychology and education and organizational sociology. We draw from frameworks that help us understand behavior and behavior change, so that we can then figure out, when I talk about intervention components, I'm talking about the ingredients. What are going to be the ingredients as a knowledge translation intervention that we can co-design with practitioners to get to that who will do something differently. And importantly, not just for scientists and not just for practitioners, but also for managers and leaders, how can we measure that there's been a change? And it isn't only about change at the practitioner level. What everybody really wants is to measure a change in patient outcomes. So one of the other very important messages that I want to leave you with today is the importance of tailoring the intervention to the problem. Like I said, once you sort of quote unquote diagnose what's happening, you want to be able to tailor the KT intervention to address the specific barrier, leverage the support that's in place, and hopefully that's how you get better uptake of scientific evidence. So let's see how we do this, right? So evidence-based practice, I've been arguing for this, about what's in this white box for quite a while now. It is the business of those who educate future physical therapists, right? It starts there. The puck starts there. The attitudes, the knowledge, the importance of embracing an evidence-based practice approach starts in education. But it is also the business of those who regulate practice and policy and those who employ physical therapists. And the reason why I say that is because traditionally we have a very good body of research that shows that these different sectors, education, practice, policy, everybody has a vested interest in evidence-based practice, but for the longest time we've been working in silos. And we work in silos because we have different mandates and different timelines and obligations and limits, and I would even say currency, right? What matters very much to a researcher in terms of that currency, right, is different than the practitioner on the ground. And our timelines are different. Research takes a lot more time. Practice can change quite rapidly. So though everybody believes in evidence-based practice, its ethos, its importance, we've been working in silos. So what this has led to, this is my own personal experience, and we now have data to support this. It makes for discouraged and often disheartened practitioners, right, who feel that some of what's going on is not under their control. So we have argued that it's a shared, evidence-based practice is a shared responsibility. We need to co-create the processes and the strategies together that bring the different perspectives together such that actionable solutions can be implemented. So I'm not here just to talk theory. I'm not just here to talk pie in the sky. I'm here to give you suggestions. So what can this actually look like concretely in practice? So I'm going to start with education. I'm presuming some of you might be new graduates or seasoned clinicians. Some of you are likely preceptors. So I'm going to make some suggestions about what should we do really early on. We should really drill the important message of how important using evidence in physiotherapy practice is, for the reasons I've been giving you throughout this presentation. The scientific evidence is vital. We need to also drive home to our learners that there's different ways of knowing that scientific evidence is incredibly important, but so is clinical experience and acumen, and so is the patient-generated knowledge and evidence, right? The narratives and the stories that our patients tell us that help us with the decision-making process. We should teach our students the three-circle model, but we shouldn't stop there. We need to tell learners that evidence-based medicine and evidence-based practice have evolved over 30 years. We need to stop teaching them only about the three circles. We need to continue to teach knowledge about how to search and appraise evidence, okay? And I know that some clinicians will say, and they said it to us very clearly, I can't do this, or this is too difficult for me to do. The good news is that more and more we're seeing pre-appraised evidence. We're seeing decision-making tools. We're seeing guidelines that have done some of that work for you. So what I would argue is in education, let's spend a lot of time teaching our students how to use the evidence, how to bump up against intentionally difficult case scenarios where they'll have to deal with the tensions between the evidence and the context and the patient's wishes. Let's do that in collaboration with our preceptors who then have our students in their sites. Let's not forget to talk to students about context so that when they get into a clinical practice environment as a student, as a clinician themselves, they're not disillusioned to see some of the good and some of the less good about context and how context can really shape our decision-making. We need to prepare them in advance for the barriers that they may encounter, but we should also really drive home all the supports, all the great things that are being done currently in rehabilitation practices that need to continue to be leveraged. We need to, why not? We've started at McGill doing this. Let's introduce students to what knowledge translation is, the process, why we need to do it, and encourage them, even if they're not scientists, to engage in that process, right? To go into practice and to say, oh, I'm seeing some gaps. What can I do? Who can I work with? What can I begin to leverage to try to address some of the barriers? So why not expose our learners early on to the field of knowledge translation? That is the vehicle for evidence-based practice. Here is the crux. What do we do in clinical practice? I'm going to suggest some small things and some much bigger things. Use alert systems, right? You work in a specific area of practice. I'm not suggesting you read 10 papers a day, but use an alert system that actually sends you in your email a paper or two that are new in your area of practice. You don't have time to read it in depth. Read it in diagonal. Know that there is something new in your area or something controversial in your area. Read as much as you can, considering the constraints that I mentioned before. There's a growing literature on the importance of supervising students. I often say this is a marriage made in heaven, preceptors and students. You're marrying clinical experience and acumen with that heavy theory knowledge that our learners are bringing into the clinical environment. When you're asked to sit on panels for clinical practice guidelines, you're asked to sit on a panel to suggest how to make evidence more applicable in practice, please consider joining. This is how you make the scientific evidence that's being generated more applicable and more relevant. This is when you tell people like me, this is not going to work in the way that you've packaged it. Implementation strategies, I won't go through all of these. These have been shown to be quite effective. Workshops that come into your clinical environment with discussions and chart audits are very good to get you to think a little bit about what is being done, when was it being done, how close or not it is with the scientific evidence. It's been discussed as a reflective tool, not as an assessment of your competence, but as a vehicle for self-reflection. So you get a second slide because this is a really important one. Recognize and reward evidence-based practice. And I'm not suggesting you put, a poster on the wall with the employee of the month. What I'm suggesting is when you see, when around you there are teams and individuals who are working towards implementing evidence-based practices, name it, recognize it, and reward it. Without making it explicit, people don't know that that's necessarily what's happening. Co-construct with peers and clients. It's not an individual process. The evidence-based decision-making process is a co-construction with our colleagues and the people who are trusted in our care. Recognize how important your professional experience is and your acumen, and how without it, you can't make decisions, right? One of the fathers of evidence-based medicine said very early on, evidence doesn't make decisions, people do. But recognize when it could also be a stumbling block, when it might be stopping you from having a broader perspective that includes evidence that maybe you hadn't thought of or hadn't read about or were unfamiliar with. Again, your context cut yourself some slack in some ways. Context is complex. I talked a lot about it and how it might influence what you do relative to a colleague in the same department or a different department or a different institution. We know that local champions, which have been called different things, champions, advanced practice leaders, knowledge brokers. We had a PhD student who did their whole work on knowledge brokers and champions across Canada, who actually found that when these individuals are identified, they're not the Alikis of the world, they're clinicians who have garnered the respect of their peers and who are put in a position to help translate some of that evidence into practice. Advocate for access to resources. I can't emphasize this enough. As self-regulated professionals, we must be able to say, without X, I cannot do my job. I need access to the literature. I need access to a webinar. I need some time to be able to discuss complex cases with my patients. And develop a culture where physical therapy practice isn't just about patient direct care, but you become, as a knowledge generating field, also a vehicle for knowledge translation, that you are above and beyond a service provision, that you as a profession, you are also have a responsibility to disseminate knowledge, to participate in it, and to try to promote its uptake. In terms of policy and regulation, what I would say is that it's important to collaborate with practitioners who understand the daily challenges and opportunities related to EBP. And I say this to policymakers, I say this to regulators, I say this to professional associations. Have you spoken to the people on the ground? Have you heard the reality? Have you considered the impact of this new policy decision? Have they been at the table? I think the policy and regulation should reward and recognize various metrics of success, and I recognize that this is a contentious topic. Success isn't just how many patients we saw a day or how fast we got them out of the hospital or the clinical environment. Success of practice can be measured with different things, right? How involved you've been in teaching, how involved you've been in trying to promote the uptake of evidence. So yes, practice is important, but in my opinion, so are these other metrics as well. Reward and recognize aspects of practice, as I just said, other than direct patient care. Recognize unintended consequences of lack of agency and limited choice making. And this may sound somewhat disheartening, but in some of the work that I'm doing, when I've interviewed clinicians in depth, trying to better understand what limits there are in their work environment, what I've heard is, I absolutely believe evidence-based practice is important. I'm doing as much as I can, but I'm often told what I need to do, or I'm infrequently consulted on big decisions. I'm frequently told which patients I'm going to see at which point in time. And so there's been a sense that there's lack of agency and limited choice making. And in my opinion, policy makers and regulators really need to recognize that. And last but not least, in a study that we're just completing now, we have representatives from the Ministry of Health and different organizations that have said to me, if you want us to be able to put in conditions in clinical practice environments, such as giving more time to reading evidence or journal clubs, essentially liberating clinicians or adding tasks to their workload that are not about patient direct care, you need to provide economical evidence that it's going to be cost effective and lead to better patient outcomes. So researchers are heeding this call that without economical evidence, it's also quite challenging to persuade, if you wish, or policymakers and hospital organizations and managers to put in some of these interventions that I am suggesting. So you are physical therapists, you are self-regulated professionals. By virtue of that, you are meant to have agency, and with that comes responsibility. So the responsibility is to recognize your strengths and shortcomings or uncertainties and ambiguities related to patient care and to do something about it, but not to be alone. So to recognize it. Because for many, many years, clinicians have felt disempowered and disheartened with some of the more organizational and context or systems level challenges. And we know that COVID has just amplified that even more with staff shortage and burnout and a number of other reasons. But hopefully with, though, drawing from that responsibility and that agency, you can go from being disempowered to actually being an empowered clinician who feels that they can move the needle even a little bit. So it's ambitious. I recognize that this is not just an ambitious, offering or suggestions that I'm making. We've made headways on a lot of these. It certainly should be viewed as a journey. There isn't one physical therapist that graduates being able to do all of this. The professional and competency development that comes with evidence-based practice and being a scholarly practitioner, always with the aim of providing the best possible care, happens over time, right? It is very much a function of the experiences that are afforded to us, the good and the bad and the ugly, the challenges, the strengths and the successes we've had with our patients, the opportunities that have been given to us to teach or be a preceptor or to participate in research or be a champion in our clinical environment. So it's a multifactorial issue where we need to draw from these three different sectors and recognize that if it is not happening overnight, that is also more than okay. So I would like to thank you for your attention. And I very much look forward to questions and discussion.
All right. Thank you very much. So we do have some questions that have come in. So we'll get to the first one. First one is, previously we had Doug Gross present on the funnel model of evidence-based practice. How does this, I guess, relate to the wobbly stool model or your three-circle model, or are we still kind of talking about a lot of the same things?
So if I'm understanding correctly, is the question about the knowledge to action framework that has the funnel in the middle and the steps to moving evidence into practice? I wonder if the person could just put a quick yes or no in the chat box. If it is,
I think when we were talking about the funnel model, it was like and maybe, it might be one of those things that, hasn't come up in kind of your line of research, but I think the funnel model, from what I can remember from Doug's presentation, is that funneling down of evidence plus clinician research or clinicians' best practice, their anecdotal evidence, what the patient kind of, brings to the table, and sifting through all that to basically kind of get down to the bottom. I think, so the totality of the evidence at the top, funnel through clinician experience, and then patient preference evidence kind of as you get to the bottom.
Oh, I see.
Does that
okay.
make sense?
So,
yeah.
Yes. I think it's just a different way of representing it. I personally believe that those elements in the circles are constantly acting, and they may be smaller or bigger in terms of the size. My conceptualization is not a funnel in my mind. I think that these are moving parts that are constantly interacting. I think somebody could agree that you start with the evidence and then you funnel. But in our research and in my mind, the three circles are constantly interacting. I'm not sure that you necessarily start with one. A clinician can be confronted on any day with an uncertainty or a complex case. Perhaps the first line of action is to speak to the patient, or the first line of action might be just to take some time and think about it and draw from their clinical experience. So whether it's happening simultaneously, I'm not convinced it's happening in funnel necessarily, but that is where I sit paradigmatically when it comes to evidence-based practice. So I don't know if that helps answer the question.
No, I think that does. I mean,
yes. Sorry, essentially we're drawing on the same elements, right? So the question is more about, is it happening sort of in a funnel, or is it happening as an interaction?
Okay, so we have a question from Eric from the U of A. So thanks for your inspiring presentation. At the University of Alberta, we've been reviewing how to teach evidence-based practice and knowledge translation, partly due to lack of interest from students arising from not teaching it in context and due to barriers of using once in practice. Some of our, sorry, it's just the way my screen is set up. It's hard to read. Give me 1 second. I'm just gonna. What do you suggest as means for private practitioners to see relevance and have some access such as they see the relevance?
So is the question about how those in private practice?
Sorry, just the way my screen is set up, it was hard to. The way my screen was set up, it was hard to actually read. Just give me 1 sec here. Okay. Partly due to lack of interest from students arising from not teaching it in context and due to barriers of using it once in practice, some of our students and teachers suggest we may not need to teach appraisal because too many of our grads practice in private settings without access to peer-reviewed information. What do you suggest as means for private practitioners to see relevance and have some access to actually the relevant information?
Right. So was that Eric? Did you say that was from Eric?
Mm-hmm. Yeah.
Yeah. So thank you for that question, Eric. So Sean, maybe I can send you after the webinar. We just published a paper that's a bit contentious. It was called 30 Years of Teaching Evidence-Based Medicine, Have We Been Getting It All Wrong? And it's in there, Eric, that we bring up all the issues that you bring up, how difficult it's become to teach evidence-based practice because we argue we don't really know what it looks like in practice. There's very few clinicians that walk through that 5-step process. And so if you're teaching evidence-based practice as a 5-step process, and then you go into clinical practice, and that's not what's being done, it's very disheartening for students who feel disillusioned, right? Or young clinicians. We've heard in one of our studies, it was called the opposing worlds. Like we weren't talking to each other. We were training them for something that didn't seem to be happening in practice. And so I think that if we're graduating folks who are then going into different practice settings with limited resources or a range of resources, I think that the value of evidence-based practice, the ethos, as I've been mentioning, really, really has to be emphasized regardless of where you're going. Right? Regardless of where you're going to graduate, you have a responsibility to try to stay up to date with the scientific evidence. Now, I recognize that, as I said in my presentation, many clinicians don't need to appraise the evidence. For some areas of rehab, we have pre-appraised evidence and we have summaries of the evidence that we can draw from. So I think it's also mentioning that during the educational experience that you will sometimes have to read a paper very quickly and try to see how it applies. But in other cases, for example, Stroke Engine. Stroke Engine is a premier knowledge translation intervention website that has assessments, treatment interventions, all pre-appraised for patients, students, and clinicians, right? So there's CP Engine, Cerebral Palsy Engine, where there's more and more of these resources that you could, at a click of a button, you can actually get some of this information, even if you don't necessarily have a library or access to the original research.
Okay, so next question in line. A common complaint is that the evidence doesn't exist to answer the clinical questions, or that the methods are not described in a way that could be applied clinically. This can be discouraging for students and new PTs who are trying to incorporate evidence-based practice into their clinical practice. What are some easy ways to help reinforce the use of evidence in practice for new grads?
So researchers have heard that call, that comment, that complaint, so to speak, loud and clear, that we are generating evidence that is either not relevant, applicable, usable, so it stays inert, it's not actionable. And this is why there's a sort of subset or a subcategory of KT, which we're now calling integrated knowledge translation, where we're developing studies from the get-go. Everybody at the table includes the people at the table, include researchers and patients and families and clinicians, so that we're trying questions that matter to the end users. So that's been going on for a decade or so. So hopefully that's going to generate more actionable knowledge. In terms of the strategies, we've just finished a couple of studies and have papers out suggesting that the new graduates are doing a really good job. So I'm not sure if the comment or the question, Sean, was about a personal experience of a new graduate not having embraced an evidence-based practice approach, but the challenges are less with the new clinicians, unfortunately, than they are with more seasoned clinicians, because we also have studies to show that the further away you are from graduation, the less likely you are to stay up to date with the evidence. So I'm a bit less concerned with the new graduates. I think what the new graduates need is mentorship. The new graduates need mentorship from seasoned clinicians to make sense of the evidence. But they also need clinicians who are themselves champions of evidence-based practice. So I agree with the comment and the previous question where if you're promoting evidence-based practice tremendously during the educational experience and you go into a context where there are very varying attitudes, it could be disheartening for a new graduate who need those role models, right, to continue to sort of shape that embracing of evidence-based practice, because it could be very disheartening for a new graduate that's been hearing for 2-3 years how important EBP is to come into a clinical environment and to see no use of evidence. So this is why knowledge translation is happening at the same time. And I sort of live in both worlds, is trying to understand what's happening in clinical practice, how it could change so it could better feed back to the educational environment. So I hope that answers the question in part.
Yeah, and I think the question came from somebody who takes a lot of students, and so they do have a lot of, PT students that come through their clinical practice, and I think that's kind of something that maybe they were hearing from their students, is that they know the research. When they delve into the methods, there's not really enough of a descriptor to kind of really break into, okay, they did, these specific things. This is how we're going to apply it into, my day-to-day.
Right.
So I think that was the basis.
So I would just add something.
Okay. Yeah.
Sorry, Sean, I'll just add to that because it just reminded me that I don't think we will ever get to the point where we tell clinicians how to use the evidence. I would worry personally that could be a little bit of a slippery slope, because clinicians are trained, are educated to reason, right, and to reason professionally. Evidence at our disposal is only one tool in that decision-making process. So the exercise and the challenge lies in what do you do with that knowledge? What do you do with that evidence? So we can provide guidance. Researchers can provide guidance. Clinicians can work with researchers to say, how do we make this actionable? But I worry about the day coming where we say to you, this is how you use it, because that would remove not just the power of professional reasoning, the agency of the clinician, but also the fact that in rehabilitation, our environments are messy. Not all of our patients are the same. So one-size-fits-all approach to EBP is not going to use. So that I would worry about that a little.
No, I think that's a really good take on that. Okay, so this is kind of a common theme that I think has come through kind of in the question. So for those of you who are asking as well, I would go back to our 3-part series that we had on evidence-based practice. I think some of the answers might live in there, but we'll get Dr. Thomas's take on this as well. So not every clinical problem has a practice guideline. What is the minimal level of evidence that should inform practice paradigm shift? So if you're going to change your practice, is there like a minimal level of evidence that you think would be worthwhile in order to kind of create enough of a impetus to make that clinician change their actual day-to-day practice? Note also that a lot of accessed systematic reviews, meta-analysis have not so clear conclusions, making the appraisal of the evidence difficult for a busy clinician. also take in mind that practice guidelines take time to produce, and some of the information could potentially be stale. And so that kind of leads into, again, like for busy clinicians, how do you know the evidence that you're accessing is high level or pseudo evidence? And I think, again, like I said, there's some of this has been answered in our 3-part series on evidence-based practice that you can access via our webinars, but we'll get Aliki's take on it as well.
Yeah, I mean, that is such a question. I recently gave a talk that was called, how much does it take to change practice? And it was not in the context of rehabilitation, but the person that asked the question is absolutely right. We don't have evidence for everything. We are starting to have evidence for a lot of things. Not all of it is very strong, but in many areas and many MSK conditions, we have evidence. Back pain, we have evidence. Arthritis, we have evidence. Stroke, we have evidence. Many areas of pediatrics, we have evidence. Developmental coordination disorder, we have evidence. So, is it going to take 50 RCTs to change practice? To be honest, don't we owe it to our patients and to society to start making some changes, even with the evidence that we do have? We are not suggesting to use it blindly, and we are not suggesting, the KT scientists are not saying, use it or blindly or wait until there's a systematic review, because we don't have systematic reviews for everything. And some systematic reviews, as the audience member rightfully pointed out, often lead to inconclusive findings. And so we have our clinical experience, we have principles of rehabilitation that we know. We've been trained to know that, stroke affects X, Y, Z, right? And we have mechanisms, right? It's called mechanistic reasoning. We have mechanisms that we know are hopefully likely to lead to a given outcome. So, do we have randomized clinical trials for every single intervention, for every single pathology or condition? No, but all the ones that I gave examples for before are pretty good areas where there is existing literature. The issue we're finding is that there's limited uptake. So there has to be a better understanding of why, in spite of that evidence, which sometimes is very strong, sometimes not so much, why there is no greater engagement with it. So even the lower level of evidence, right, that even if it's not a systematic review of meta-analysis, even if it's a cohort study or a prospective study or a qualitative study that gets you to better understand the lived experience of someone, all that knowledge is very powerful in shaping how we think about our clients and what we do. So we're not always going to have the randomized controlled trials, but I argue that a very strong qualitative study that talks about how parents are dealing with a new diagnosis of a child with autism is very powerful in terms of how we think about how to support parents as rehab teams. As briefly as I could there, Sean.
No, you did great. Okay, so a couple more still to go. How do we ensure that clinical evidence is not clouded by bias? We know that patients will report benefit, and this is sometimes clouded by the desire to please the provider, or potentially in other instances, it could be clouded by their own belief in their treatment selections. Still others are potentially affected by timelines for collection of that evidence, so immediately at the end of a course of treatment. So when we look at the clinical evidence that we're taking in our day-to-day practice, are there ways that we can kind of look to see whether or not that's, clouded in those kind of mentioned biases that exist?
Oh, I love this question. I'm not sure who asked it, but this is a question that requires another hour of conversation. And the reason why I say that is because I've done trials. I am not a trial. I'm not an epidemiologist, but I will tell you that what some people call bias and noise, people like me call rich information that just contributes to the decision-making process. So I'm not suggesting that a randomized clinical trial that's poorly executed with bias is a good thing. No, if you decide that you're going to do a clinical trial, you want to try to limit those confounding variables and you want to have it as pristine as possible. But remember, the more pristine the experiments are, the less their external validity, right? So their ability to sort of more generalize, because clinical settings in rehab are much, much messier than the experimental conditions. So bias. You're all physical therapists. I'm an occupational therapist. When I teach my students on clinical reasoning and evidence-based practice, I say to them, your strength is your reflexivity. Your strength is your ability to critically reflect on what you're drawing from when you're making a vital decision with a client, not for a client, with a client. We're doing way more shared decision making than we've ever had. So I don't consider the patient contribution, my clinical acumen, as sources of bias. I think they are very valid sources of information that have to be taken into account side by side with the evidence from a randomized clinical trial, for example. This is one opinion. For the person who asked the question, you could have 10 researchers that will give you different opinions. But in rehabilitation, given the complexity of the cases that we deal with, to me, those other things are not noise. They're rich sources of information.
Perfect. Okay, we just had one follow-up question from the U of A. Can you describe how the teaching of evidence-based skills is distributed in the School of Rehab at McGill? Is it integrated into your clinical courses?
Oh, yes, what a great question. So yes, I did my whole PhD on, how to sort of figure out the best ways to do this. So we actually have, based on a very robust literature on developing competencies and expertise, we have weaved evidence-based practice throughout the curriculum. And so it starts mentally, it goes on, more about what is it and how to do it and the steps and the attributes. And then when they get into a year that's much more clinically applied, then there's complex cases with messiness and context and discussion. We bring in patients. And we've been working tremendously with our clinical community to make the links. We actually just, believe it or not, I know it's 2022 and we should, maybe should have done this 10, 15 years ago, but we finished a study a couple of years ago on clinically integrated teaching of the EBP. And so we did a study with preceptors and faculty members in OTPT and SLP. And we came to some conclusions on how best to do it. The number one strategy is partnership. So clinicians have to be teaching in our program, and then we give back to the clinicians on best practices relative to how to teach it. So it's called CIT, Clinically Integrated Teaching. I'm happy to send those papers, but that is one very strong evidence-based way to do it so that the two worlds are not opposing. So as soon as the students get to a point where they have a little bit more clinical experience and they're exposed to vignettes and cases, that's where we start making the cases and the context more complex, because that's what it looks like in practice. Nothing is pristine in practice. And Sean, I'm happy if this would help, I'm also happy to send you a couple of papers for anybody who may be interested.
Yes. Okay, so I think that is all we have for today. Questions have all been answered. So once again, I'd like to thank Dr. Thomas very much for her time today and the quality of her presentation. It was very well done and I think very well received based on the amount of questions we had come in.